So this is the DNB December 2025 paper 3, part 2, questions 6 to 10. Part 1, the questions are very normal GIT hepatobiliary. Similarly, this part also has very normal expected repeat questions, nothing very complicated. So let's go with the first one. There are two parts to the question. First part is scoring systems for GERD. Now, you need to have a little bit of idea because just like that, if you start thinking, it will be a little difficult. So at least you should know the basic ones, basic classifications, and how will you grade the severity? Because when we look at scoring systems, the idea is I want to know severity. So either you go 1, 2, 3, 4 and write a few points about each, or you can make a table like this where you name the systems, their role, and a few key points. Right. If you know the exactness, that's even better. But at least this is the very basic you should know. This will get you easily 4 out of 5 marks. So when I think of GERD, I think of 3 scores. One is clinical or system score. Okay, so questionnaire based. That is the HRQL score. So quality of life questionnaire. Second I think of is endoscopic scoring. So endoscopic is a very famous LA grading. These two are the ones we commonly use in practice. And sometimes if you want to do a 24-hour PH study, that will tell you the Demister score. So these are the 3 basic scores. The fourth one, this Hill classification, is more for hiatus hernia than a GERD alone. It's more a hiatus hernia score. So little bit about each. First is I have written your Demister score. That is the one which you measure by doing the 24-hour pH study. So you should write a little bit about it, where in 24 hours the nasal catheter is put, which measures the pH in the distal esophagus. It also reports patient symptoms and it matches the two. And normal score should be less than 14.7. If it's more than 14.7, it is significant of reflux and the matching of symptoms with the reflux. Right. So that is the relevance of the Demister score. LA grading tells you severity. So here, at least LA grading, you should know grade A, B, C, D. Grade A is breaks or erosion less than 5 millimeter. B more than 5 millimeter. C less than 75% circumference, multiple breaks. And more than 75% is grade B. This is very commonly used by endoscopes. Then you have a quality of life questionnaire. So here the patient has to fill a questionnaire where he talks about heartburns, episode, severity, dysphagia, impact. And this is normally used before after. What was his score before treatment? What was his score after treatment? And this Hill classification is basically telling you tightness of GE junction or tightness of the diaphragmatic crura. So the looser it is, the more risk of hiatus hernia. That's what it kind of tells you. So these are the 4 basic scores you should know. First 3 are extremely important and used in practice. So the main message is see how to write the answer for these kind of questions. Similarly, part 2 of the question is easy. Complications of lap anti-reflux surgery. Now here again, I've covered a similar topic before. Complications of MRND, complications of chest tube insertion. So same kind of logic you should use. Intra perioperative, post-operative early, post-operative late, or perioperative post-operative, or just early and late is also fine. But make sure you make some kind of a differentiation. Some kind of categorization is required. It will make your life easier and it will make your answer, look better. So intraoperative complications, you can talk about laparoscopic complications by itself, like port access problems. You can traumatize the epigastric vessels, traumatizing the bowel. That is the simplest post-op entry problems. Then during the surgery problems, you are dissecting the GE junction, so esophageal or gastric perforation, splenic perforation, tail of pancreas injury. Those kind of things can happen, and pneumothorax. These are what can normally go wrong intraoperatively. Post-operatively, now this is not related to lap alone, this can happen in any anti-reflux. Most common is dysphagia. Usually it is short term if it is due to edema around the wrap, but if it persists, it could be a very tight wrap. Gas bloat syndrome, atelectasis, wound infection, normal. Late complications, persistent dysphagia, or inadequate anti-reflux, so recurrence or persistent GERD, rarely there can be herniation, right? Because of rapid migration. Vagus nerve injury can happen, but in today's day and age is quite rare. So this is how I divided the complications, and you can write a few details about them accordingly. This is a repeat question. This has been asked once before. Causes of post-cholecystectomy bilioma and management. Basically, they are asking about acute bile duct injury in short. So why do you get a bilioma post-cholecystectomy? Obvious reason is there is a bile leak from the cystic stump, the clip slipped or the ligature slipped, or it could be because of injury to some other duct, accessory bile duct, right posterior duct, or common hepatic duct, CBD. They are the dangerous ones. It can be a thermal injury, or rarely, it can be a missed biliary obstruction, like a biliary stone, which can cause a cystic stump to blow out. So if I got a CVD stone, which I didn't notice pre-operatively or intraoperatively, but I did the cystic duct clipping, the pressure will be high, and that will cause the cystic stump to blow out. Even rarely, it can be because of introp spillage, like you did the cholecystectomy, gallbladder burst, some bile spilled, that can also cause a bilioma. So these are the usual causes. Notice you need to give some structure over here like I have given. That will get you full 4 marks in this part. The second part is you must have studied this. You may have even managed these patients. So management of bile leak after cholecystectomy. Now, how does one do that? First part here is you write a little bit about the clinical features. Like when he got the bile leak, how would it manifest? Usually, a bilioma will manifest in the post-op day 1, 2, 3, where the bile was leaking, person started getting pain in the right upper quadrant. He may have just gone home. It may just be 1 or 2 days since he has been home. He started getting fever and he came back to you. So you are worried what's going on. How can a patient get worse after going home? So you palpated, you were like, oh, there is tenderness in the right upper quadrant. You are thinking of a bile leak. First step, obviously admit the patient. Don't send them home because a bile leak can be lethal. You can start with some basic imaging to confirm that there is a bilioma. A bilioma is like a collection in the GB fossa due to leakage of bile. So either you do an ultrasound, which is a good first line investigation, even better will be a CT scan. And if a bilioma is confirmed, the first thing you're going to do is drain it. Either you put a pigtail image guided, or if the person is having peritonitis, it's a big bilioma. In that case, you may have to do surgical drainage and just give washes and maybe leave some abdominal perihepatic drains. So that will be the first step. Once patient is stabilized, then you want to know which duct is leaking because any of these are possible. So to locate the leak, you can do MRCP or ERCP depending on the timing of the presentation. And if it's a leak which is amenable by MRCP or amenable by ERCP like a cystic leak, you can stent the bile duct. But if it's a complicated leak, a leak where there was a proximal injury or right posterior sectoral injury, which can't be managed by stenting, in that case, you will have to do a delayed reconstruction.